Everyone, welcome to the third and final installment of Proclinical's Future of Healthcare webinar series. In the past webinars, we've discussed the emergence and the importance of telehealth and telemedicine, respectively. And within that, we've seen a massive increase in the amount of quality, the amount and the quality of health data being collected. With this in mind, we wanted to focus this panel discussion today on the importance of data within the healthcare space and how it can help improve outcomes, lower costs, and drive greater reliability within the digital health and medical device industry. Before I get started, I just wanted to make a few introductions. My name is Rooney. I'm a principal consultant here at Proclinical. I've spent the last 2 years growing out our digital health capabilities on the West Coast. During this time, I've been fortunate to work with some of the leading digital health startups within the Bay Area and across the US. Predominantly, I've been working with these teams to grow out product and engineering capabilities, but sort of generally digital health specialists sort of within Proclinical. Joining us in the background today, we've got Claire Perry, who's a VP here at Proclinical. She's predominantly focused on the executive level placements within medical device and digital health space. Claire's got over 7 years of experience within recruitment, and the majority of that's been spent in the life sciences space. She'll be helping on the backside of this during the presentation, so she'll be running through the slides and collating any Q&A questions. So please feel free to drop any questions into the Q&A box, and we'll make time to answer as many as we can. To give a quick overview of Proclinical, we're a global growth partner to the life sciences industry. We've got offices in the UK, we've got offices in Europe, North America, and the APAC region. Historically, we've been focused on the pharma and biotech space, but over the past 2 years or so, as I said, we've added to this within the medical device and digital health capabilities, which are only growing sort of day by day as we add to our East Coast and European teams in these areas. We wanted to put on these webinars to allow for an opportunity for people to network during obviously difficult times with COVID, and also to give something back to an industry we're very passionate about and we value very highly. So joining us today, we're very fortunate to have a really strong panel of people. So we've got Peman Montazemi. He is the Director of Software Engineering at Diality. They are a home hemodialysis business. We've got Michael Giske. He's the CTO advisor to Scripps Research, Wealthy, and Westpak. And we've also got Corinne Stroum, who is the Vice President of Utilization and Cost Solutions at KenSci, who are a machine learning startup up in Seattle and focused on the healthcare space. I'm going to let you guys introduce yourself sort of in a little bit more detail. So Peman, do you want to take it away and introduce yourself first?
Sure. Thank you, Louis. First of all, thank you so much for having us part of the panel today. I'm certainly looking forward to it. Peman Montazemi, at Diality, we're in-home dialysis solutions, and I'm Director of Software there. And over the past 20 years, I've contributed about 4 years to the nuclear industry, nuclear software specifically. My previous teams and I have actually codes that are deployed over 93% of nuclear power plants in the United States. And in the remaining 16 years, about 9 products that we have released to the market across 5 different companies successively, and big fervent of major architecture from the get-go, having requirements in place that are very, very solid, and we can certainly cover that a bit more during the discussion. But thank you again for having me.
Fantastic. Thank you very much. We'll go down in the order. Michael, do you want to go next?
Yeah, thank you, Louis. And thank you, everybody, for joining today. I'm really excited to be part of this panel and part of this discussion. And what an exciting topic. Personally, I've had the opportunity to work on many large-scale solutions initiatives that started in different areas other than life sciences. So actually, my career began with Porsche AG in Germany. But throughout my career and experiences, I've really enjoyed looking at innovative ways to apply technology to problems that we all try to solve and face in our everyday life. And it was in 2004, I think, that I got the opportunity to work with Genentech in particular, where I was allowed to work on on a game-changing commercial blueprint initiative that really overall applied the latest technology ideas to Genentech's growing international business. And so that experience really helped me understand better and appreciate what tremendous benefits technology can provide to the life science and healthcare space. Since then, I've worked in many other life science and healthcare facing opportunities, and had tremendous opportunities to work specifically focused on genomics analytics initiatives. My current focus, as Lou stated, has been in a more CTO advisory role to support several other organizations with their technology undertakings. And as we will hear in this conversation, a lot of their issues, I think, are germane to many of our collective issues and questions. So I look forward to the conversation.
Fantastic. Thank you very much, Michael. And then, yeah, last but not least, Corinne, do you want to just talk us through your background?
Good afternoon. I'm Corinne Stroum, and as you mentioned, I work for a machine learning company that focuses on healthcare data. So I am a huge healthcare geek and data geek. My passion has been that this year has brought us so much more data. And as your prior two sessions have focused on, a lot of this is much more consumer generated and consumer centric. I'm excited to bring conversations about this to the forefront today, but also take the approach of overall data literacy. I am also an instructor at the University of Washington teaching this exact topic, and understand that, you know, some of what we talk about today is extremely high level, extremely advanced, but it is becoming increasingly important for every person to be well versed in topics of healthcare data analytics. Thank you.
Fantastic. Brilliant. Yeah, thank you everybody for being here. I really appreciate all your time and obviously all your insights that we're going to go into in more detail. So just before we jump into the panel side of things, I thought it'd be important just to overview sort of where data is at, sort of, and sort of the data and AI landscape. So as you can see, we've obviously got a bunch of companies who are completely focused on data. There's obviously your massive multinational corporations like Amazon, Google, Microsoft, etc. They've got a big hand in the data space. But what we've also got is we've got some smaller, more niche businesses focused purely in the healthcare and life science space, which is a little bit out of the ordinary. It's a little bit of an anomaly within healthcare that we've got startups who are purely focusing on healthcare data, and sort of not many other industries have that. So it's just worth highlighting, and just sort of, this is obviously by no means an exhaustive list, but it's just a good graphic to show sort of what's out there and sort of what the current landscape is. And then before, again, we jump in, just wanted to sort of outline what we're talking about when we say healthcare analytics, just to define and sort of put some parameters on a pretty big subject that we've got to discuss today. So healthcare analytics is the healthcare analysis activities that can be undertaken as a result of data collected from 4 areas within healthcare. So there's a claims and cost data, pharmaceutical and R&D data, clinical data, and then patient behavior and sentiment data. So the healthcare analytics is a growing industry in the United States, and it's expected to be more than 31 billion by 2022. So as I said, the industry focuses on clinical analysis, financial analysis, supply chain analysis, as well as marketing, fraud, and HR analysis. Healthcare analytics allows for the examination of patterns in various healthcare data in order to determine how clinical care can be improved while limiting excessive spending. So without further ado, we're going to jump into the actual panel section of the webinar. What we want you to do is, obviously, as we go through this, if there's any questions that pop up, please feel free to pop them in the Q&A box. We will try and get to them at the end of the session and set some time aside. So yeah, let's jump into the questions. And then the first one, we're going to open up with a fairly broad one, just because I think it's important to sort of start there. The first one we're going to go for is, where have we come from and where are we heading in terms of with data analytics within the healthcare space? And Michael, do you want to start us off on that one?
Yeah, sure. I think it's an exciting question to ask, right? Because we really have made tremendous strides. And if you look at the overall horizon, there have been key trends that have really catapulted us to where we are today. I think everybody acknowledges there's one of the three key trends is the evolution of data in itself. We've seen how we've gone from traditionally large-scale warehouses that are really managing, I'd say, in the upper echelon of terabytes structured data for mostly. That's been the domain, the environment that we lived in and worked for a long time. Eventually, lots of events happened that produced so much more data. And data suddenly became more than just structured data. It became semi-structured or completely unstructured data. We're using images, et cetera, PDF documents, you name it, whatever we may want to refer to here. These are all unstructured data types that we are now considering just as valuable as part of our analytics discussion as the traditional structured relational data that we've been used to work with. Similarly, metadata has evolved tremendously. We've seen metadata formats evolve as a result of that tremendously. And so we've gone through several iterations from an initial XML to then eventually a JSON, and from there into a more columnar focused using standards such as Avro and ORC optimized roles. I really apologize.
You brought Olaf.
Okay.
Dad, you brought Olaf with the kinetic sand.
Okay. Can I help you in a minute? Can mommy help you?
And you brought Smiley Face in the kinetic sand.
I love you, sweetie. Let me help you in a bit, okay? Daddy still has to finish this reading, and then I'll help you. I'm terribly sorry.
It's very interesting that they're also interested in the data analytics at that young age, actually. It's very nice to have that.
I should use that as my segue. Segue being into the other key trends that I've been talking about. So data in itself has evolved tremendously, but then there's also the evolution of analytics in itself. We've all come to know certain standard statistical methods to do certain data analysis over time, but it was a lot of cultural and technology exports over the last, I'm going to say 30 years that have catapulted us into the types of machine learning algorithms and approaches that we are now considering a mainstream, almost mainstream approach to analytics. I reflect on scenarios such as Berners-Lee, when he researched the nuclear fusion related aspects, he realized that a World Wide Web type of collaboration would be key to his success. And that's how the World Wide Web was born, right? So I think we oftentimes forget how interconnected and interdependent the various aspects of our lives are in terms of driving certain technologies forward. You look at the first key trend data, the vast accumulation of phenotypical data that we're now assembling in the context of mobile devices or wearable devices that we're wearing, all of that is contributing to a tremendous shift in technologies. And so modern statistics has evolved as a result of what I'm describing here in the analytic sense. We've added so many more modern statistical methods, linear regression is an example, and various other clustering, k-means algorithms, and what have you. Those techniques didn't exist for all that long. And it was really the result of the vast data that's been accumulated that's driven us to look at what statistical or mathematical means can we pull in to solve these problems, meaning analyzing data that's far bigger, far less structured than we've ever seen before. And that leads me to the third trend. And I think the third trend that was really key, if you think about in terms of bringing us together to this current state, is genomics. Data has been a huge issue for astrophysics, right? Nuclear fusion, as an example, had to deal with vast amounts of data in itself, but we're seeing how genomics is quickly accelerating and quite honestly exceeding most of the data sets that we've ever had to deal with in any other industry, never mind healthcare. So I think, genomics is the trendsetter, and so in so many ways, genomics has led to other we call now omics-related initiatives. You know, we're using metabolomics data, we're using phenotypical data, as I mentioned, wearable devices that just hadn't been in existence until iPhone and Android devices started to come to the rescue, if you will. And proteomics, you know, understanding the relationship between proteins and interdependencies is driving another huge data push in the analytics space. So altogether, that's where we've come from, and this is where we're heading, is clearly needing to apply a transition from what I would call typically coined a descriptive or diagnostic analytics approach to now more predictive and even prescriptive or preemptive type of analytics approach. And so that's a huge shift, right? So we're asking questions differently. We're not asking what happened or why it happened, the descriptive or the, well, we're still asking those questions, but more importantly now, we're keen on wanting to understand how can we predict events like this to happen in the future, and what could we do? What type of decision support systems in healthcare can we introduce, or other disciplines, to preempt those types of events from even occurring, right? That's the direction we're taking, and I think we're seeing evidence in the evolving technology space. We've got Google Genomics, we've got Microsoft Genomics, we have solutions like Databricks that are understanding that the disciplines of traditional data science and data engineering really need to closely merge and collaborate and become one fusion, if you will. That's the word today. So I could go on in terms of how there are so many areas that we need to focus on that really drive our next future. You know, I think developing and designing data architectures that are very flexible and dynamic. We've seen how we had to adjust from our existing structured data approach to now supporting these new structured, semi-structured, unstructured data types. The need to ingest data, not just in the traditional batch processing mode, but ingesting data real-time, streaming data, and analyzing as we're streaming it. Those are concepts that all need to be baked into our thinking. The idea that we used to have traditional data warehouses that no longer can support really the massive parallel processing capabilities that are required to analyze data at the large scale that we are using today. Those are all key concepts that I think we need to focus on as we're heading forward, along with several other aspects that probably would take too much time to go into depth here, but I look forward to maybe later some more follow-up questions on that topic.
I think, Michael, you hit a major chord here. So with on the genomic side, you know, when you know, I had actually a cousin of mine. It was interesting that we're working on protein mechanics, and protein mechanics we're working on basically on trying to see the binding of proteins with drugs basically and simulate that interaction at the protein level. And so we were discussing this over the past 20 years together, and to see where computers have come from to be able to compute that, it would take weeks and servers like, you know, occupying, you know, an entire room to be able to simulate one drug interaction, to be able to simulate and come up with the right drug for any kind of cancer, etc. And so now, you know, imagine the data of that at the protein level going somewhere, which is also massive. And then imagine the infrastructure from not just a database, but also the computational that is needed and the space that it requires. Now, what you hit on is like everything right now can be actually in one place, which is, you know, you can have the cloud and, you know, all that data computationally, it's a lot faster. And then you can have that, you know, to the back end of any kind of database and analytics that you want to run, etc. So I think the power of the century we're in and this specific decade is really on the fact that everything is centralized in one place, and then we don't need to run it on a laptop or run it on a super desktop that costs $5,000 or $10,000. It's like everything is centralized in one place, which also, of course, accelerates tremendously because you have these clusters of servers for that specific application that can run them, you know, overnight.
I think the theme that I heard from Michael and Peman is threefold. Number one is we have new data. And that's a huge, huge victory for all of us in various forms of life sciences, medical devices, and healthcare delivery. Second is technology that very practically wasn't made for us is something that we are benefiting from greatly. The anecdote that I always share in machine learning is everything that makes ads target you are things that we love in healthcare because it helps us to target protocols, therapeutics, et cetera. All of the best recommender systems, all of the best machine learning techniques went through the ringer in consumers, mainly because you see scale and because dollars follow it. So we've definitely benefited from technology. Even AWS and sort of the elastic cloud notion really also came out of a need from massive e-commerce. But here we are using it across distributed hard science industries. And then, of course, one thing that I think was sort of an undertone in what both Michael and Peman said is philosophies have changed. We've all become far more conversant. I saw one of the attendees actually piled into the chat to say, I've been teaching my children about data. And I think that that's huge. I know that when I've been looking at sending my own daughters to kindergarten, there's actually topics in the curriculum about data already. And at first I was hesitant. I thought that maybe that was too early, but I realized that this is the world that we live in. This is the world where we are surrounded by the data that we generate, the data that we interact with on a daily basis. And I think people are starting to see that. I think when we've tied these all three together, I look at a role that I held about 12 years ago working in a hospital where we would generate this report of utilization statistics every week and mail it out to the whole team. It was members on this particular therapeutic protocol and sort of the impact. Nobody read that report. And it's because it used those basic descriptive statistics, average duration, who had the highest duration. Is that really useful information for anyone? But now we're trending that forward. We're instead of saying, I'm just gonna regurgitate back to you a summary of everything that you already know, we're drawing your attention only to the data that matters. And we've educated you to understand why that data matters. We're now telling you, instead of, this is the person who had the longest duration of the treatment and that exposes them to a risk of infection, let's now say, who's the person most likely to get the infection? Or who's the person most likely to have an extended duration of percutaneous treatment? It's been an interesting transition to see people's palette for consuming this and for data and analytics informing some of their decision and some of their protocols.
Fantastic. Thank you very much, everyone. That is really great. It was a very broad question, so it's good to go into as much depth as we did there. So next question I wanted to go into is, over the past few years, and obviously particularly in the last 6 months with COVID, adoption of telehealth and telemedicine has dramatically increased. How do we think analytics is going to support this transition? Corinne, do you want to start off on this one?
Yes, I suggested this question because this has been a unique change to my day-to-day life, is understanding that this is a form of data reflecting a very different distribution of care. There's two important distinctions that I like to think about when we talk about telehealth. Number one is that we hope that it actually makes care more equitable, that it reduces some of the barriers to obtaining care. People who could have had transportation issues or could have had a cost preventing them from accessing care should ideally have some of those barriers taken down. And we've seen too that legislation backs that. Telehealth until early this year was required to be AV. You had to have a video chat just like we're having now. But that didn't work very well in rural areas, areas that were disconnected, areas where people didn't have cell phone plans. They didn't have smartphones. And now we're seeing a move towards audio only, and we're seeing a move towards asynchronous messaging as well. And what I like about this is that that does bring us into very good data analytics opportunities from an equity perspective. Are we seeing broad adoption of telehealth, or are we seeing that it's just perpetuating some of the inequalities in healthcare? That's a very easy set of analytics that we can run. But now we also get analytics that very practically we weren't seeing before. Voice and sentiment. I was chatting with Lewis prior to the kickoff today about call centers have been using this technology for quite some time, but it's rather new in the delivery and administration of healthcare because you weren't being recorded in visits and you weren't gathering some of that summary data. And this reflects more of your experience as a patient, as a consumer, as a caregiver than we've ever gotten before. We used to administer surveys and they would rate your, experience, but you had that, dichotomy of great experience, loved this doctor, to worst doctor ever, never going back. But now we see that modulation over the course of that encounter. So I would say, number one, telehealth is giving us a bit more in forms of equity and in the forms of experience. And then I would also say that we've got, unfortunately, a similar opportunity to now investigate exactly the techniques that Louis discussed at the head of the call: fraud, waste, and abuse. One of the first things that we saw early on when telehealth was expanded was things like providers billing more hours of telehealth visits than there are in a day. And there are analytical techniques that keep this safe, because if we're trying to bring down some of the barriers to care and to distribute the care out of a single, monolithic healthcare system setting, then we need this to be done appropriately. Otherwise, we will all fail together. So we've been investigating some of the techniques to ensure that any untoward utilization habits are surfaced quickly and addressed just as quickly, so that we can keep riding this amazing momentum for telehealth.
Fantastic. Thank you very much. Does anybody else want to jump in on this one?
Please go ahead, Peter.
Sure. Thank you, Michael. So one thing I was going to say is, as specifically in the medical device space, one thing that is very critical is to see exactly, where that channel of communication gets established. Is that the medical device, level? Is it an external, tablet or a mobile application that happens? And depending on the complexity of the system, but also cost and, the bill of material of the device, etc. I've seen people taking certainly different routes and saying, okay, is the device that we have as a tester, is a caregiving device, for home, and specifically for home, and then should the application run on the medical device itself or not, or should it be when the doctor needs to call me, should it be on a tablet or a mobile phone, etc. And these architectural decisions are actually key to know at the beginning where they're going to be embedded, because obviously they tie into the bill of material of the device, and they tie to the bandwidth that the device uses. And are you going to connect it also to Ethernet, to Wi-Fi, and then eventually is it everything going to be embedded in one device, or are you just going to use your phone or your tablet to be that? So it's very interesting that all these get entangled into making decisions that ultimately, of course, benefits the patients, but at the same time the business model makes sense. That's just one observation.
Cool. Michael, do you have anything to add at this point, or should we?
Perhaps just really quick, concur with the different aspects that have been brought up here so far. And what we've seen at Wealthy as an example is tremendous insights, analytics insights from understanding, for instance, where people live versus where they work, where people live versus where they go to school. And is there, in fact, a correlation between a certain spiking of infections between either your place of residence or your place of work or school? So those types of analytics insights would have been difficult to model and understand not too long ago. But these days you can use most of the off-the-shelf. We used ELK as an example to do various anomaly detections and understand very quickly from there. Do we see a spike within a certain employer workforce, right? Those are key insights that were really tremendously helpful to everyday scenarios and in helping people really stay informed and understand, oh, wait a minute, we've got a spike over here. This is something we need to actually react to very quickly, right? So that's one area I found to be extremely helpful. Another form of health insights that we gained from our initiatives was to see, in fact, the distribution of different devices and down to OS level distributions of systems used to access telehealth, and it was quite telling how much of in our particular example we saw a significantly larger portion of iOS devices participating versus others. So not sure. It's always been of interest to me to see how much that is true for the larger population, but in our setting, that was very insightful.
Mm-hmm. Cool. And then sort of, I think the next one's probably best directed at Peman. Obviously, you've spent a long time sort of working with very high risk environments in nuclear and medical devices, making sure everything literally has to work. So how do we use data to help build systems that don't fail? Sorry, you're muted, Peman. Peman, you're muted. Still muted.
Oh, I get a pop-up.
There you go.
Thank you.
No
So we drive it from the requirement of the needs of the system. Of course, we're not going to make a system that is, quadruple, redundant, like nuclear. Most of the nuclear systems are, because failure is not an option. But in some cases, some medical devices are actually, sustaining and doing life support and things like that. Ventilators are one example of it. And at that point, it's very, very important to look at both ends. So from an architectural perspective, right off the go, where you design and build redundancy into the system. And in some cases, you need to have a fail-safe mode and things like that. But on the other end of the spectrum, and which is really the topic of today's panel, is that you have data on the other end. So we look at the data that we expect to come out of a certain device, or we expect to be used, and weave that into the requirements to actually architect that specific device for that specific, basically, market. Now, of course, the more stringent you get, and then you get to aerospace, defense, and then nuclear, etc., the more stringent we're going to be in architecting that. But one thing that we have observed is that after the first, let's say, the release of that specific device, the data is actually being collected and for basically spinning the next architectural revision of it. So it's not only that we have, bugs or defects or any kind of problems with the machine that is reported in the field that we look at that, but not only that, we also look at the data that is, coming from its sensors, data that, how the device is being used in the field. And then so you have, once the data becomes available and then you start categorizing it and you put them in these different baskets, you have various teams that actually attack it. It's no longer marketing anymore. At least no longer just marketing. Because marketing looks at it and said, oh, we would like to get this feature, that feature, that. You have several groups that are looking at that now. They're looking from an architectural perspective, what are the different rooms for improvement. We look from the data to see, how our patients and end user are actually using the device. Are they having any problems in the flow or the original design that the machine was designed for, or the device has been designed for? Are they actually making different uses of the device? Like they invent sometimes some different workflows. They use a workflow that the machine was actually not designed for, and we see that very, very much in the ORs. And then so what you gather that data to do what? To actually collect modes of operations that the machine wasn't initially designed. And sometimes it actually opens a complete different market, because whether you can incorporate into the same device or you actually design a different device that actually serves that specific custom mode of operation, because let's say some surgeons are very specific about their workflow. So that's another piece. And then the last piece, of course, is R&D and engineering that come and look at that data, and they would like to look at service data. They would like to see, what parts have failed, where do we need to put a reliability growth to see, the cycling on the machine. Let's say that the machine is, designed for 10,000 cycles or 1 million cycles. Well, it's going to fail after that. And then so imagine that you have a patient that is connected to one specific device, and let's say the pump that is inside requires basically maintenance. Well, where is that data? The patient is going to see a very annoying message, say, okay, the pump has to be replaced. Thank you very much. What am I going to do with this data? But if you have some kind of a predictive maintenance that happens, on the machine, that the company or the clinic that is serving that specific medical device knows ahead of time that we're kind of reaching basically the kind of the Pareto data and the number of cycles that we need to be from a reliability perspective, then at that point you can do any kind of predictive maintenance on the machine, and then you're going to have basically zero downtime, because you either do a swap or the parts just gets replaced, and the life goes on, and then you still continue, providing the support and the care that the patient needs.
There's a
Really
technique.
interesting.
Oh,
Sorry.
sorry.
No, carry on.
There's a technique that I know Peman probably uses all the time, which I think is, to me, the most critical element of designing complex systems. It's failure modes and effects analysis, FMEA. In my medical device days, I adored this process, and I carried it forward into my work in software as well. And I think it's worth sort of recapping what this is. Start with the failure and work backwards. So how will your system fail? And this is actually something that we start with very early on in any solution, even in a predictive environment, because very fundamentally, your prediction can be wrong. And so you need to understand, what does it mean when it fails, and how do you mitigate or remediate that failure? How do you design for it upstream? If you just search this out, there's a good, I think, ISO standard template about how you design FMEA into your protocols. I think it's a principle of how I even operate my daily life, because you do have to plan for those failures. And that is a critical element of complex systems, is they will fail. And if you design for them accordingly, you can offset that a bit. And in our case, we also design into, how do we prefer to fail? What is our preferred failure mode? Do you want to cast that wide net and capture as many people as possible, potentially getting those false positives? Or do you prefer to get false negatives and to say, I'd rather not over aggressively target people. I'd rather get just those that I know will be correct. And so we constantly walk this decision line of how we prefer to fail. And then what we do in those cases, how do we provide enough supporting information? How do we ensure, using the statistical techniques that Michael was evangelizing earlier, that we catch it? We have control and quality systems that we can put into place to ensure that we detect it and automatically address it or raise it to the attention of someone who can.
Yeah, it's to complement that, and thank you, Corinne. We actually do a system hazard analysis from the top down, using the ISO 14971, and then you're absolutely right. From DFMEA, you do bottom up, and to see any kind of failure modes, and then you capture them there. So again, the safety of patients is something that we can negotiate, or safety of the end user. So that's how we cover our grounds from a process perspective. Yes.
Fantastic. Yeah, thank you very much. That was great insight there. So let's move on to the next one. I think we're going to look at like security and privacy next. I think that's sort of a key thing when people are discussing data, whether it's what like Facebook collects or whether it's what your doctor collects. People are really interested in how people are securing their data. So how are we going to address the increasing security and privacy aspects moving forward within life sciences and healthcare? Michael, do you want to take this one?
Sure, yeah. I think most anyone attending this call is very familiar with the challenges we're facing. There's some interesting statistics that show again, my space, genomics being something I'm ultimately familiar with, you look at the vast amount of data that we're accumulating at this point. And this goes back to what I said in the beginning. The trends that have evolved have led us down a certain path, leading to certain security and privacy dilemma, if you will. And so what I'm hinting is the trends that we've seen evolve led us to a distributed cloud platform approach. I think we collectively can acknowledge that for a vast majority of our problems, we now need to rely, it's not just an option, we need to rely on cloud grid computing as the platform to operate on. And that opens up a lot of opportunities for data breaches, for security violations, for data privacy compromises that shouldn't be made in the first place. And so I think when I look at numbers, there's a projection that says we're going to have 2 to the power of 40 exabytes of genomics data accumulated over the course of the next 3-4 years. And from there, we're probably going to move into zettabytes and what have you. The enormous amount of data that's being accumulated in this context, in particular, but in general, not just on a local or nationwide, but actually global level, is the key question to address. And so my my focus traditionally has been to look at first and foremost, what are US regulations that we need to follow and adhere to. And so there are clearly very common compliance mandates instituted. But what I found interesting is in my research and honestly in my own day-to-day observations is, and so the OCR, the Office of Civil Rights, has done an interesting study on this topic. And they said the vast amount of, I'm going to call it all medical data in whatever form that we may decide later, but is being compromised on the basis of many operators not even understanding the regulations themselves. So it's as simple as that. It's as simple as certain institutions perhaps understanding HIPAA, but not understanding how HIPAA and PHI need to be considered in conjunction. How in some cases, this is especially true for educational records, you have acts such as the FERPA Act, which is the if I can remember right, Family Education Rights and Privacy Act, is another set of regulations to focus on, depending on the type of data that you're needing to manage and control. When it came to genomics data, GINA was instituted, which is the Genomic Information Health Act, to ensure that it supports more specifically genomics data as part of the overall HIPAA umbrella. And so what I'm hinting is there is no doubt a vast body of regulations and standards to be aware of and to follow. However, my first big appeal here, I think, is for any one of us working in the industry is to actually make note of the importance of those regulations, because frankly, without those being even pushed into awareness and being followed, we are fighting a lost battle. It's very obvious that security can't be enforced, privacy can't be enforced, if there's no definition even within a given organization what that means. And so, I think personally I've enjoyed working with evolving frameworks such as HITRUST to achieve some level of common understanding. If you're not familiar with HITRUST, it's a common security framework that is internationally adopted and understood and accepted. And it incorporates various ISO, NIST, HIPAA compliance mandates into an actual, I like to always compare it to the how framework. HIPAA is the what. What do I need to protect? Same with PHI, what have you. But how exactly am I going to go about it? Well, HITRUST gives you a very well defined framework for different levels, by the way, level 1, level 2, 3 distinctions, so that you can achieve some level of, I'm going to call it peace of mind, of operating in the space with what I consider very important and very valuable data. The other part I want to highlight is privacy is something that is on the forefront of a lot of organizations' minds, because it's more so a consumer-centric, a patient, in this case, patient-centric issue, right? Because I have consented to you using my diagnostics results for your specific, maybe it's my specific healthcare analysis, should not constitute you to use my results for various other studies unless I consent to it, right? And so it becomes a question of data privacy, in my opinion, on a global scale becomes more and more a question of data ownership. And so we really need to embark more and more on how can we globally protect data in a consistent manner? Because just because I did a 23andMe genomic sample submission over here, and now somebody in Europe got a hold of it and decided to do whatever they want to do with it, that doesn't make it right? So the idea is, ideally, we have a common understanding of how data that's being accumulated, whether it's genomics, phenotypical, or you name it, any of our healthcare data, how is this data then consistently and commonly commonly agreed upon terms managed. I like to defer oftentimes to GA4GH. That's the Global Alliance for Genomics and Health. In their efforts, I think they've done a tremendous effort in reaching, if you will, a standardized consent practice. I think that's where our focus needs to be going forward, is essentially addressing the multitude of data breaches in the context of not understanding, foremost, what are the regulations that I'm expected to oblige to. Then from there, what are the types of privacy and consent mechanisms that I should incorporate into my data management architecture? And then from there, what are the types of data ownership? And this, as we can all agree, is going to translate quickly into why data has become the crown jewel, right? What's the value of my data? Because I think we're realizing how more and more data accumulation is becoming an entryway into a lot of money. And so I've seen statistics on how 23andMe, as an example, benefited tremendously from a general submission of genomics profiling to then sell it out to other types of clinical studies and what have you. The question begs, should I be participating in the monetary benefits since I'm consenting to this data to be used in such fashion? And so I think data use, data privacy, data valuation are all concepts that we need to start baking into our data management acronyms and into our data management architectures. That's really where I'm hinting. There's a lot of other topics that I would love to get into, but I'm going to give some others the time here.
Sure. Thank you, Michael. I think when we get to the implementation side of it, lately the FDA since 2019 has become quite picky about data, and not only at rest, so that means that in any kind of memory that you're actually storing it, but also while being transported, whether it's over Ethernet, Wi-Fi, Bluetooth, or even in the embedded side inside the device itself that is actually shooting data up to the cloud. Mm-hmm. So one very useful exercise is actually to go through the UL 2900, whether now, thank God the FDA is not requiring at least medical device manufacturers as we speak to be compliant with the UL 2900, but as the sandwiches, have been added and the sandwich has become bigger and bigger, I wouldn't be amazed that this actually becomes a requirement in the future. But this exercise is very, very important for any kind of device, whether mobile or not, because we have to talk about threat actors. We have to talk about the environments in which, a cybersecurity or a cyber attack can happen, and then how the company handles. I'm not even talking about the SOP and having a cybersecurity plan in place, but I'm also talking from the purpose of really driving the entire software, the entire embedded system that actually supports any kind of threat through this exercise to understand all the penetration points. And of course, the next thing that that is a very useful exercise is to do penetration testing. So the sooner, so the sooner we actually, get and expose the early baby, the architecture in its infancy to any kind of process like that, there's the possibility to have a first pass at it. And then once we implement and add the layer of sandwich of cybersecurity architecture, then of course the advisement is to do a second penetration testing to make sure that all the nuts and bolts are fully tightened. And then of course do the submission, and because they look at every single penetration one, cloud, device, mobile applications, and so
I couldn't agree more, and I think that the separation and distinction between security and privacy here is really important. I think also that the overall challenge that we're seeing is that data is, as I was trying to allude to, used in many different ways than other than what it was initially intended to. And as a result of that, we're seeing personally de-identified information still being attached to metadata that actually retroactively lets me re-identify the person. And we've seen several data breaches of that nature now, where what we consider to be safe data sharing is not the case, because the operators didn't understand what it means to truly de-identify information and isolate that data from any other possibly compromising metadata. So I think those are the examples that I'm thinking of, in addition to what you just described, that we really need to start thinking about, because it's easy to assume, accumulate data lakes of data. It's difficult to manage and control the access and the usage of that data across different, not just internal, but other external parties use cases. And I think that's where we're heading, is with the event of analytics in the cloud, we're extending data into the universe rather than just our local confines.
I think too, there's a significant consumer aspect here. Michael, you cited a few really key operator errors that I see daily. You know, we'll use a very compliant architecture, and then someone sends me a screenshot with PHI in it, right? It doesn't take much. And I think that this is one of those hazards that's very hard to mitigate when we go back to that concept of complex systems, because user education, user training is not the best, if at all, acceptable means of mitigating risk. I think that the architecture itself needs to be context aware enough to know that joining this metadata with this de-identified data risks re-identification. It really needs to be baked in. And it's not an easy task. Now we're getting into sort of more concepts of HIPAA expert determination than anything that we could potentially automate, because the moment that you try and just strip out the protected identifiers, you've immediately nullified the value of your data. I've seen attempts at de-identification where we strip out all the foreign keys. So now we just have a bunch of unconnected events just hanging out, and we can't do anything with it. So I think that this kind of goes back to some of the platforms that we use and some of the architectures that we source from right now, needing that shift and needing to understand sort of the intent of their consumers and how to prevent those consumers from making those mistakes. Because the screenshots that I've seen, those inadvertent joins, they're not done with malicious intent, but they're done with the failure to keep up on any one of the various and sundry, lettered acronyms that we've cited today in terms of privacy and/or security.
Mm-hmm. Fantastic. Thank you very much. I think we're going to do some Q&As. It doesn't. We've had a few comments, but not necessarily any questions. So I just wanted to, we've got about 6 minutes or so left before we want to wrap up. So I think one good place just to finish on, and everyone can pile in, but I think Corinne, this is one of yours. What skills can a layman acquire to better understand data within healthcare, just on a broad spectrum?
Yep, I planted this for a reason, because we are all subject to it. And I think that it is the most imperative thing for us to understand what data we're generating, who has access to it, what they're doing with it, and the context in which that's occurring. I've always envisioned this amazing future where instead of my phone telling me it wants to access my, microphone or my photo gallery, that I get a ping from my medical record that someone is using my data as part of a study, because that's actually fantastic. I would love to know that. And I think that disappears behind enterprise business associate agreements, and we don't see it. I'm seeing my connections unstable. So if I'm going robotic, I'll just say basic data literacy. Understand the context in which you are generating, storing, accessing your data. What are you being sort of collected within? And as a consumer of data, a healthy dose of skepticism is pretty key. Whenever I'm given a data set, I always ask, what was inclusion criteria? What was exclusion criteria? Let's say, is behavioral health excluded from this data set? Many times we don't even think to ask that question. And that can very much skew, particularly for a machine learning model, your cohort of interest. So just get to know your data sources and prepare yourself to ask the hard questions, and also get versed on concepts of visual analytics so that you can make quick judgments about your data using a quick self-service tool like Tableau.
Any final thoughts on this one? We've got a few more minutes. We can either dive into a new question or sort of add some more to this.
Well, I would echo what Corinne just said, and I think overall, you know, in my opinion, a good entryway to get started is really benefiting from the vastly evolving platforms that are becoming now standard tools in an online setting. So if you haven't played with any of the analytics tools out there, Google Colab is an example. It's a wonderful way to really get very quickly started on some basic data science initiatives. For those of us who have used perhaps Databricks and are familiar with that platform, it's a wonderful environment again, because as I mentioned earlier, it really aggregates in an easy way more the typical data science type of components, along with the data engineering components, which I think is critical to have that actually in one place. And so I think it's starting to get more easier, I'm going to say, for people to really get into it. I look back at 5 years ago when I was trying to do my first machine learning efforts, and understanding TensorFlow and everything that comes with it, and getting deep into, should I write this in Python or Scala, and it became a bigger effort. So seeing the types of tools that are evolving in the online learning environments that are helping you to get started is significant.
Anything to add on this side of things, Peman?
Nothing on my end, no, thank you.
It's your turn to unmute, Lewis.
There we go. I was using the spacebar to temporarily unmute and just let go. So yeah, sorry. I don't know if we've got enough time to go into another question. So I think it's probably time to start wrapping up. Unfortunately, maybe we can put something together for the questions we didn't get to go through, that we can share sort of with the attendees at a later date, maybe. So if everyone's interested in that. But yeah, what I want to do, I just want to thank everybody for being here today. I say Corinne, Michael, and Peman. It's been fantastic, very interesting conversation to go through, and obviously everyone who's attended. What we would like to encourage people to do, say this is a form of networking, sort of during COVID, which is a good thing to do. Encouraging people to connect with us all on LinkedIn. If there's anything that you didn't get an answer to that you wanted to see, feel free to reach out to myself or Claire or any of the panelists, sort of to go into any more detail. And I think that's something that everyone's going to value and everyone's going to get something from. So yeah, I think we've got another minute left, but if anyone has anything else to add, just quickly.
Thank you for having us. We appreciate the opportunity, and
Thank you very much.
stay safe.
Fantastic. Thank you very much, guys. Have a safe rest of the week.
Thank you. Bye now.
Thank you.
Thanks.